All right, so the case that we're going to present, the patient that we had the privilege of taking care of, is a 60-year-old gentleman with past medical history significant for non-ischemic cardiomyopathy, stage D heart failure, treated with an HeartMate 3 implantation in August of 2018, who is now presenting to the ER with 72-hour symptoms of fatigue, dizziness, and lightheadedness in the setting of having numerous LVAD low-flow alarms. His comorbidities also include hypertension, COPD, hypothyroidism, and recurrent GI bleeds. The presenting vitals are somewhat concerning. For borderline low blood pressure, MAPs are in the mid-60s, and a heart rate that is significantly elevated at 163 beats per minute. Physical examination, again, the patient is ill-appearing, awake but drowsy. Interestingly enough, the pulmonary examination is pretty unremarkable. Cardiovascular exam, you appreciate the hum of the LVAD. The JVP is elevated at 12 centimeters, and the patient does have hepatojugular reflux. Extremities, again, a red herring, are actually a concerning sign, cool and dry, but no lower extremity edema. Current medications that the patient was on at the time of his presentation, again, a pretty standard cocktail that you'll see a lot of advanced heart failure patients on, so nothing alarming there. The LVAD was interrogated in the ER when the patient first arrived, and it's consistent with low flows. The current flow was 2.4 liters per minute. The current PI was 2.8. And interestingly enough, the patient had had 37 alarms in the last 48 hours. Review of the log files, again, consistent with the fact that the low flow had been persistent long before the patient was symptomatic and had been going on for several days leading up to his symptoms, which further prompted him to arrive in the ER. EKG, again, consistent with ventricular tachycardia and explaining some of the symptoms that he had been having. And thanks to the LVAD, the patient was not dead and was able to make it to the ER. Labs, again, if you, on the quick review of this, concerning for cardiogenic shock with evidence of end organ hypoperfusion in the setting of an elevated lactate, elevated LDH, creatinine being elevated, and a BNP that was elevated as well. Thankfully, the liver had not taken a hit yet. So the initial differential that our team had in this patient was that it's probably RV failure secondary to the persistent arrhythmias that the patient had been experiencing, or it was intravascular volume depletion, or this was a case in the setting of an elevated LDH that this was prompt thrombus leading to the low flow alarms, or there was concern that it could have been an inflow cannula obstruction or an outflow cannula obstruction. This is the TTE that was performed at the time of admission. I apologize, these were supposed to play in loop, but they are not. But as you can see, that the ventricle was significantly dilated, and of note, the inflow and the outflow cannula velocities were normal at the time of this presentation. So day one, on the day of the presentation, the patient is cardioverted to sinus rhythm with a single 200 joule shock. The pump speed is reduced to 4,800 RPMs to help protect the RV, which is, again, at the top of our differential right now. The dobutamine is started at 5 for concerns for RV stunning. The low flow alarm still persists, and at this point, a PA catheter is placed and the patient is transferred to the CIC for further care. So right heart catheterization, again, consistent with elevated right and left-sided filling pressures, and the PA pulsatility index was 0.6, and the CVP to wedge ratio is 0.48. So as has been discussed at this symposium, that oftentimes the invasive hemodynamics may not be all congruent and may point in different directions. Day two, the day I recall, is the calm before the storm. The patient diuresed well, and the filling pressures improved. The low flow alarms resolved, and the flow was now 3 liters. The LVAD was ramped back up to 5,800 RPMs under TTE guidance, and the patient remained stable for the next 24 hours. However, for not very long. On day 3, the patient started having overnight alarms again that were continuous, worsening CVP, worsening mixed venous saturations, cardiac output, which was now equal to the LVAD flow. Dobutamine was again increased to 7.5. The patient was given some fluids. The LVAD speed was decreased to 5,200 to see if this was again the RV that was causing the trouble. Milrinone was started, and the patient was given more fluids to see if that would make a difference in this case. At this point, still the top of the differential is the RV, and there's concern that it may be that's what's driving the symptoms. And so to take that off the shelf, the cardiogenic shock team was activated and for RV support, and the patient was taken to the cath lab for 29 French Protect Dio. For those not familiar with it, this is what the device looks like, and here's the x-ray of the patient after the device was placed. Brings us to day 4, where the RV has now been successfully offloaded with the Protect Dio. The LVAD fluids still do not significantly improve The LVAD speed is ramped up to 7,700 RPMs to obtain a flow of 2.8. Rest assured, this was done after close consultation with the engineers who said that it would be safe for us to ramp it up this high for up to 48 hours. And in order to match the right and the left-sided filling pressures and make sure that the LV was not flooded with the output from the Protect DO, the Protect DO RPMs were reduced to maintain a cardiac output of 3 liters per minute. The low flow alarms resolved, but not again for very long. And at this time, the patient is restarted on dobutamine and epinephrine for left ventricular support. Here comes the time when our differential shifted a little bit, and we thought that this was probably primary pump failure, and the surgical team decided to take the patient to the OR for pump exchange. Here comes the moment of truth. So this is what we saw on the surgical exploration, and what it shows up here, if I can point, is the area of interest is right up here, where you can see that the outflow cannula is actually kinked, and that's what's causing these symptoms. So to bring this back to the title of the slide, that anything that can will go wrong, and reminding of something that my attending used to say, that if you don't think of the zebras, you will never find one. And that's what happened in this case as well. So how often or how common is this? And the article that we were able to find showed an incidence of about 0.7%, and is often a late complication of an LVAD implantation. In our patient, the patient had an LVAD implant about a year ago before this presentation. The mechanism still remains a little unclear as to how this happens, and in a small study evaluating patients with HeartMate 3, they found that there was no difference between those that had a twist and those that did not, as far as the geometric relation of the apex pump and the outflow graft is concerned. The diagnosis can be made with the fluoroscopic angiography of the graft that shows a typical sandglass appearance, or a CTA. In our patient, the CTA or contrast exposure was limited because of the concerns for AKI, and the definitive treatment remains surgery. Would like to thank my mentors for all the help over the years, and thank you for this opportunity once again.
That's a great case. Why do you think the echo didn't show acceleration across the kinking?
Not very sure, but I could not include the echoes even before the patient went to the OR and stuff, but we have 3 sets of echocardiographic image, on all of which the inflow and the outflow velocities were normal. Though my best guess is that it's probably the way the images were obtained and the cuts that we had, that we probably were not able to get the max velocities on those to show that that's what was going on.
So,
but that's something that definitely challenged the presentation.
so if I may comment, excellent presentation, but I think the echo showed you everything you needed to know, to be honest with you. When you go through the differential low flow post-implant, you know, the patient came from clinic, you said, likelihood of overt RV failure, tamponade low, dysrhythmia, your CVP was 12. And if this were RV failure causing low flow, you would see the interventricular septum bowing into the left. So you had partial alveolar loading and LV failure, and your exam and echo confirmed that. You know, the interrogation of these outflow cannulas in the inlet in terms of velocities to detect kinking or resistance at the pump, very, very poor. And so one could have done, you know, a ramp and prove that the LVAD wasn't doing its job, but I think the clinical presentation showed you that. And so I think many centers would then say, okay, we got to determine where along the outflow cannula is this a problem in terms of the swivel and twist or obstruction and kinking. And so CT angiography can be helpful, or going to the cath lab and doing, attempting to see that. So I think it was a nice case to illustrate that you had an outflow cannula on your differential that could have been prioritized as the problem.
Absolutely.
Because your wedge was 30 and your CVP was,
right.
This was an LV problem.
Mm-hmm. And I completely agree with you, Dr. Isab, in the sense that there is definitely an anchoring bias in what happened up here. The guy came in with prolonged VT for 6-7 days on his device interrogation, and coming out of the ER of the initial evaluation of the patient, it was all over the charts that this is probably RV failure, and the hemodynamics are to be explained. And it just so happened that over the next 3 or 4 days, that was kind of carried forward, and the window was not really expanded as far as what else could be going on if this is not the RV. Part of the reason why he got the Protect DO is because we wanted to take that off the table and kind of end that discussion.
So, but the point being for the community, the diagnosis was wrong.
Yes, absolutely.
I mean,
absolutely.
I'm playing, but, and you knew that when your wedge was high, and the number one cause of right side of heart failure is left side of heart failure. in the presence of an LVAD. And so you had to explain the LV failure. The guy presented with, like he didn't have an LVAD, right, in heart failure.
Absolutely.
So that I think that was an opportunity.
I think, the other thing is that if you're veering away from a CT scan because of renal considerations, all of this can be diagnosed in the cath lab. You can get beautiful IVUS images of this. You can do functional studies across it. We've done that. With the added benefit, if you're set up to go ahead and take care of it, you could just stent it right there. We've stented at least 10 of these LVAD cannulas that have kinked. We've also decommissioned them with, vascular plugs and whatnot. And the IVUS images, going into it, you think, okay, well, is IVUS even going to have the far field imaging to tell you what you want to see? I mean, if you use a 20 megahertz catheter with, with ChromaFlow, you see everything that you need to with minimal contrast.
I have to add, if the principal concern was BT causing the problems, dobutamine shouldn't be the first type of treatment for that patient. Second, there was a lot of speed changes on the LVAD that were pretty drastic to me. I mean, 54 to 4800 and then to 5800. And for sure it's not going to help with the hemodynamics on that patient, even if he has or not RV dysfunction. And yes, I think the Swan gas was giving you the diagnosis up front that this was LV failure, and the echo was very clear. So I think those are my comments.
Absolutely. So I think the choice for dobutamine was based on the blood pressure being on the lower side, and also the renal, the AKI that we had was partly what drove that. And completely agree with you. I mean, for the sake of presentation, I made it sound more dramatic in the sense that it was not that we went up on the speed right off the bat. I mean, these were over a period of several hours kind of ramped up to that, but you're absolutely correct. This happened within 24 hours. These were changes that were made each day to see if the hemodynamics can be improved.
So great presentation. I think in the interest of time, we move on. Thanks so much. Invite the next presenter, Dr. Tripkov.